In this lecture, we will discuss Prinzmetal's or variant angina, including its underlying pathophysiology and EKG features. Prinzmetal's angina, which is also referred to as variant angina, results from coronary artery vasospasm that leads to total occlusion of the coronary artery. Okay, so if you look here, we have our vasospasm. So here's our image of the heart. We're taking this artery and making it bigger, and notice how these arrows are showing collapsing of our coronary artery to the point that there's almost a total occlusion. Okay, so you have vasospasm of that coronary artery, and that's what we refer to as this variant or Prinzmetal angina. So that's the underlying pathophysiology. Now, this vasospasm and consequent myocardial ischemia and chest pain is almost always transient, resolving before infarction ensues. Okay, so we have ischemia because, remember, it's almost total occlusion because this artery is becoming irritated, vasospasm, and not allowing blood flow through. Okay, it's blocked there, so everything downstream becomes ischemic. Now, because the coronary artery becomes totally occluded, ST elevation develops just like in a myocardial infarction. However, this ST elevation will be transient, occurring during the time of chest pain. The ST elevation will be localized to the leads overlying the region involved, with reciprocal ST depression in leads opposite to that region. For example, if we have transient vasospasm occurring in the lateral wall of the left ventricle, okay, so a coronary artery like this one here in that lateral portion of the wall, okay, we'll have ST elevation that may be seen in leads 1 and AVL with reciprocal ST depression in the inferior leads, okay, just like a MI or myocardial infarction. So the patient has this chest pain, and during that episode of chest pain, okay, imagine that we have vasospasm in an artery here on the lateral wall for left ventricle, okay, our left ventricle sitting here, so on that lateral portion of the wall. And remember, we have leads 1 that sit here, and lead 1 that's or AVL, which is a high lateral lead, okay. Then we have our inferior leads. Here's lead 2, here's lead 3, and AVF, okay. So if this area is seeing ST elevation, we get reciprocal ST depression in these leads here down in the inferior leads. So you can see that here. Notice here's our lateral leads, 1 and AVL. Our ST segment is elevated, and then we look at our inferior leads, we see reciprocal ST depression, okay, because we have total occlusion of that coronary artery during that vasospasm episode. Now, the ST elevation may be followed by T-wave inversion, which may persist for days to weeks after the episode before actually resolving. All right, let's review what we discussed before we end here. So Prinzmetal, or variant angina, is due to coronary artery vasospasm. Okay, we have total occlusion during that vasospasm episode, and the patient experiences chest pain during it. Okay, that's why it's the angina, meaning this type of chest pain that they have. Now, the vasospasm and ischemia typically are transient, okay, and they resolve before an actual infarction develops. Okay, so we see these EKG changes during the episode. However, if you record it maybe 10 minutes later, you may not actually see ST elevation and the reciprocal changes. Now, on the EKG, we said transient localized ST elevation, localized to the artery that's involved. So we mentioned if we have a lateral artery or an artery in the lateral wall involved, we may see ST elevation in leads 1 and AVL, okay, as well as maybe V4 through V6, those left lateral precordial leads, okay, and then you'll also see reciprocal ST depression in those inferior leads, or whatever leads are opposite or mirror towards the leads that are showing the ST elevation, okay. So during those episodes, they have chest pain, and we said that could be followed by T-wave inversion in those leads with the ST elevation that may persist for days to weeks afterwards. Well, that's the end of this lecture. We discussed Prinzmetal's or variant angina, including its underlying pathophysiology and EKG features. I hope you learned something.